Good afternoon, everyone. My PhD topic is Psychological Aspects of Health Promotion and Disease Prevention. My name is Zsófia Németh. I'm a psychologist and I'm working at the Institute of Pancreatic Disease at Semmelweis University, Budapest. My supervisors are Andrea Szentesi and Péter Hegyi, and my scientific methodology supervisor is Jimmy Lee. My vision is an evidence-based healthcare system that bridges mental and physical health, promoting the well-being of individuals and communities. And my mission is to promote psychological research for better patient care and explore the potential of psychological interventions. I have 3 ongoing projects now, which I would like to show you today. My first project is investigating the prevalence of gastrointestinal disease among patients with eating disorders. Eating disorders are psychiatric disorders with one of the highest mortality rates. In the general population, the prevalence of them is 8%, but in gastroenterology practice, the prevalence is higher. We know that there's a bidirectional relationship between eating disorders and GI disease. Eating disorders can cause GI symptoms, and GI disorders can lead to disordered eating habits and eating disorders. And why is it a problem? Because patients with eating disorders usually hide their symptoms and they just receive a late diagnosis, and 90% of them remain untreated, and up to half of them never achieve recovery. Because of that, our aim is to investigate the prevalence of GI disease among patients with eating disorders. The clinical question is, what is the prevalence of GI conditions in patients with eating disorders? Our hypothesis suggests that there is a high prevalence of GI disorders among patients with eating disorders, and the clinical implication is, for prevalent GI disorders, psychologists can assess for treatment. We prepared the search key with 2 domains. The first domain refers to the different type of eating disorders, and the second domain reflects to the gastrointestinal disease. We conducted the search on November in free big database. We have the 3 key articles with the same condition, context, and population, and all of the key articles suggest that there is a high prevalence of GI symptoms and GI disease among patients with different kinds of eating disorders. Firstly, we had more than 12,000 articles. After the duplicate removal, we had 9,876 articles. We got the feedback that our topic is feasible. We submitted the Prospero registration, and now we are working on the title and abstract selection, and we would like to finish it soon, hopefully this week. My second project will be creating a protocol for a randomized controlled trial, and the topic is investigating diabetes preventive lifestyle intervention after pancreatitis. Acute pancreatitis goes with high mortality rates, and the incidence of the disease is growing. We have data that acute pancreatitis and diabetes have connection. After acute pancreatitis, up to 70% of the patient can develop post-pancreatic diabetes mellitus. And we also know that diabetes is connected with the higher severity and higher mortality rates of acute pancreatitis, and it's also connected to the higher recurrent rates of acute pancreatitis. The problem is that patients after acute pancreatitis can say for them that they are a high-risk population for diabetes mellitus, but this is totally missing from the guideline. There's no established protocol, and we can say that there's a gap on the knowledge. And our aim is to examine this situation and determine the best lifestyle intervention to prevent diabetes after acute pancreatitis. We have 2 clinical questions. The first question is, are complex lifestyle intervention an effective way of preventing diabetes after acute pancreatitis? And our second question is, what kind of resource should the healthcare system provide for complex lifestyle intervention? Our hypothesis suggests that complex lifestyle intervention is the most effective way of preventing diabetes after acute pancreatitis. And the clinical implication is, if we are able to prevent diabetes, we can reduce the risk of several health complications, we can improve the quality of life and life expectancy. We would like to examine patients after pancreatitis without diabetes. And we would like to create a 4-arm study. The first arm would receive an intervention from a multidisciplinary team. The second group would receive the intervention from just one person. The third group would receive just an information booklet with the information of how they are able to prevent diabetes. And the fourth group would receive the standard care. And our primary outcome will be development of diabetes mellitus, and we would like to measure the hemoglobin A1C levels. And some words about my third topic, which would be a Eurostat database analysis. It's investigating the effect of social support on health-promoting behavior among European citizens. We know that the prevalence of chronic disease in Europe is high, and usually in the background of this chronic disease, lifestyle risk factors are standing. Health-promoting behaviors can decrease lifestyle risk factors, and they can decrease the prevalence of chronic disease. But the problem is that these lifestyle risk factors are very, very difficult to change. And our aim is to investigate the role of social support in health-promoting behaviors. Our hypothesis suggests that social support has a positive effect on health-promoting behaviors, such as physical activity, dietary habits, normal weight, lack of smoking and alcohol consumption, and normal sleeping. And the clinical implication is that promoting social support may support health-promoting behaviors, and this can decrease the prevalence of chronic disease. And if our hypothesis is okay, and if we are true, we can involve family members, peers, and we can create different type of therapy groups for patients with different kind of chronic disease. So I'm working on this free project now, and I would like to finish my presentation with the slogan of the World Mental Health Day. Remember, it's okay not to be okay. You can heal your mind and shine your light. Thank you for your attention.
Congratulations on your presentation. I wanted to ask you, what are the differences between eating disorders and bad eating habits?
Thank you for your question. The most important thing is that eating disorders are a psychiatric disease with high mortality rates, especially anorexia nervosa, and we have diagnostical criteria to find patients with eating disorders. We usually use DSM-5 or BNO-10, so it's totally different, and eating disorders usually have psychological root. They're usually connected with anxiety, depression, self-esteem, body dysmorphia, so they have more psychological impact in this topic. Bad eating habits are also important to focus on, but they're not that serious, I can say that.
Congratulations on your presentation. I would want to ask if there is a difference in incidence of eating disorders based on gender or age, and would you want to include that in your study?
Okay, thank you for your question. Yes, I would like to make a subgroup analysis, and I would like to do it in the different kind of eating disorders, such as anorexia nervosa, bulimia nervosa, binge eating disorders, and I would like to examine different genders and different age groups as well, because as we know, anorexia appear in younger age and bulimia appear from 80 to 25 normally, and binge eating disorders can start during the adulthood as well. So yes, I would like to do a subgroup analysis, but I would like to highlight that everyone can be affected by eating disorders.
Thank you for your great presentation. I have one question. So what do you think are certain age groups or genders more affected by the eating disorders?
Some years ago, in the knowledge, eating disorders stand as the mental disease of white young women. But now we have data that 25% of the patients who are affected with eating disorders are male. So now we know that everyone, depends on the gender, age, and background, can be affected. And yes, we have to be aware of this.
Can I ask one question? It is related to your post-pancreatic diabetes. Most of the time it happens because the body and tail of the pancreas is dead or is gone forever. Because that's the place where you'll see the most of the beta cells, okay? Name 3 of them or 4, whatever it is. You say lifestyle change can help these patients. Somebody who needs insulin because of the pancreatitis. So name 3 so I can tell my patients you have to do this to get rid of your type 1 diabetes.
Okay. First of all, I would like to tell that we will include patients without diabetes. So we won't examine patients who requires insulin. We would like to focus on the patients who not yet have diabetes. So we would like to prevent diabetes.
I just have a quick question that on the first topic, you said that the main problem with eating disorder is the late diagnosis. Do you think your research will help with that?
I hope so, yes, because I think we can highlight that patients with eating disorders usually arrive to the hospital with different kind of gastrointestinal problems, and they don't arrive to the hospital and say, yes, I have bulimia, but they said that, yes, I have pain, I'm suffering from different GI symptoms, and if we are aware enough, we can detect them, and after we can give them help, and we can involve psychologists, and we can give the diagnosis, and we can treat them in the way of psychology as well.